Sampai dari sini ya. Boleh tak? Kita alih meja ni. Tak nampak slide. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, selamat pagi semua. Pertama sekali, bagi pihak diri saya dan juga beberapa perwakilan daripada Hospital Sungai Buloh yang turut hadir, ingin mengucapkan berbanyak terima kasih dan rasa amat terharulah kami di atas jemputan yang amat berbahagia ni. Terima kasih kepada Dr. Zainal selaku Ketua Jabatan dan juga Sifu besar kita yang telah pun banyak mengajar kami daripada dahulu lagi. Ya. Terima kasih atas jemputan Dr. Zainal. Dan hari ini terima kasih juga kepada Sekretariat lah telah banyak membantu daripada segala urusan logistik kami daripada bertolak daripada Sungai Buloh sehingga sini ya, dan untuk program 2 hari ini. Hari ini kita akan I will minta maaf lah, I campur bahasa lah. Bahasa Melayu dengan bahasa orang putih. Okay. So we try to make it as relaxed as possible. Walau bagaimanapun, amaran lisan yang saya terpaksa bagi adalah saya ada 172 slide. Yang perlu dan terima amaran lisan yang kedua daripada bos besar Dr. Zainal, kata perlu dihabiskan dalam masa sejam. Okay. So, walau bagaimanapun, we take it easy. Tak perlu ambil nota dan sebagainya. You anggap ni sebagai satu movie lah. Satu pawagam. Sitting pun dah macam teater dah kan. Nak off lampu kan? Okay. So, we are going to be talking a little bit about a general oversight on the management of traumatology and the services as it is, how do I say, progressing or enveloping into a change within this decade, pertinent to our country. Dia tak nak bergerak ke depan. I tekan yang salah ke? Bergerak kat sana? Tak apa. Okay. Yeah. So generally when we talk about trauma, the most of the evidences over the years have come from the military, and because most of the trauma is very much war based. But today the main trauma, because there's not enough wars for us within this region to accumulate data and experience, but everyday trauma today is happening actually on the streets, di jalan raya kita kebanyakan. Dan kita adalah sebuah negara yang boleh dikatakan kontribusi terbesar antara top dalam dunia lah in terms of road traffic injury, and most of it is not road traffic injury related death, and most of it is actually contributed by our roads. Hello, testing. B, you off I punya microphone ya. So tak apa. So boleh dengar ke? So most of the injury, terima kasih. Most of the injury is contributed by road traffic injuries. So let's take a little bit a glimpse onto the data. In 2010, 24 out of 100,000 population. Mana kata kita ada lebih kurang about 30 million population, right? So if you take by ratio, so dia tidak kisahlah size negara dan jumlah population. By ratio, for every 100,000 population, 24 people will die every year, and that's very high. So for a population of 30 million, you can estimate it's about 6,000 to 7,000 deaths every year from road traffic injury. So to put into perspective, I'll show you what the other countries are running at. For example, Singapore. Yeah, you can argue it's a small country, but since we are going on a population ratio, Singapore is 3 out of 100,000 population. Australia yang negara yang besar macam tu is 5. So kita 24. So it's pretty high. But it has gently reduced to about 18.9 in 2019. So adalah perubahan yang memberangsangkan sedikit, tetapi dia masih dalam tahap yang boleh dianggap amat kritikal. Right. So bila kita anggap 24 or about 20 over 100,000 population, we take our average lifespan as about 75. So average lifespan kita berapa? Untuk lelaki berapa? Lelaki tak tinggi sangat, mati awal. 73 ya, lelaki ya. Yang kita kurang faham ni, female average lifespan is 77. Sebab apa lagi tinggi dari lelaki ya? So at average up and down 75 lah, our Malaysian population. So at this ratio of death, your lifetime accumulated risk, every one of us is about 1.5%. 1.5% lifetime accumulated risk of us dying on the road. Itu baru roads, belum lagi homicide atau jatuh daripada bangunan dan sebagainya ya. Ya, tak apa. Other countries, for example, the countries that have contributed to the road safety, WHO road safety subscription for injury prevalence, has demonstrated, like US, the highest is also about 12.2 over 100,000 population. So trauma can say it is one of the terrible contributors of death. So dalam Malaysia ni, siapa yang mati from trauma? Is it yang dah tua-tua dah kan? Tak kisah sangat lah kot. Tapi it's otherwise not. It is actually us. Ya? Yang muda-muda ni. Terutama yang muda lah, depan-depan ni kan. Senyum bos, muda. So, below 14 years old is the highest cause of death in this country. Is below 14 years old is trauma. That's the highest cause. And the second age group below 40 pun is trauma again. Ya. Lepas tu baru datang ischemic heart disease, dan sebagainya. The thing about the data, right? When you go to NCD data, banyak resources of this country or Ministry of Health, dia banyak bergantung pada NCD data kan. Ya. Apa kematian tertinggi di Kementerian Kesihatan kan. Lepas tu duit semua masuk sana. So bab ni kalau boleh jangan record kamera tu off sekejap. Tak ada gurau je. But the thing is that trauma is being neglected because kalau kita dah tua, you will have to still die of something, isn't it? The odds are you're still going to die of ischemic heart disease, cerebrovascular accidents, neoplasm, cancer kan, and respiratory illness, pneumonia. So you will still die of likely these 4 causes, but you do not have to die from trauma. So trauma today is known as a non-communicable disease. We are trying to look at trauma as a disease. So banyak budget actually goes to the other diseases rather than the prevention of trauma. The other issue about this trauma is that the NCD is that the success of NCD should not be seen as the top 5 causes of death, tapi it should be seen as the escalation or the improvement of the average lifespan of humans. 30 years ago, 65 years ago, masa Merdeka, every average population of Malaysia is living an average 20 years shorter life than you are living today. So in this past 65 years, we are living 20 years longer. And that is the true success of NCD. So NCD should not be seen by the top number of deaths, but it should be seen by the increment of average lifespan. Singapore is 85 years old. They're living 10 years older than us at average. So it comes back to lifespan. So the focus on trauma should not be as the number of the top 5 causes of death. It is the most preventable cause of death, actually. So, but however, dalam 2021 juara mengambil tempat pertama jadi COVID lah. So cuma tinggal 0 to 14 years old is trauma. Up to 40 years old, 59 years old, lebih dari 60 tahun, semua kematian adalah akibat daripada COVID. Okay, so I just want to give you a general idea on how trauma has been neglected lah, a bit neglected disease. So it's quite important for us to focus about it. Okay. The main cause of trauma is actually hemorrhage. So, di manakah hemorrhage? Where does hemorrhage occur? So these are the various cavities where hemorrhage can occur. So if we bleed in the skull, we are unlikely going to bleed to death, yeah, because it's a very enclosed cavity. So these are considered critical areas to bleed dalam eyeballs, in the brain. So these areas where minimal bleeding can cause large amounts of catastrophe. But where you will lose a lot of blood and where you can actually avoid hemorrhagic shock or identify them is in the thoracic cavity, in the abdominal cavity, pelvic cavity, retroperitoneal cavity, and also the one cavity we kind of often forget is our musculoskeletal cavity. So the muscles can contain a lot of blood. So patients who are hypotensive, kalau kata tak ada tak ada retroperitoneal, they can be within the muscles, especially patients yang besar, obese, in bilateral femur fractures, pelvic fractures dan sebagainya. The approach today, we talk about damage control resuscitation. So what is that damage control resuscitation sebenarnya? Damage control resuscitation is not the solution. It is a bridge, jambatan, over troubled waters. Bridge over troubled waters is an interim process. It's an interim strategy. And this strategy buys us time to have definitive care and various other things. So many years ago, bila kita ada patient yang intra-app kan, so what we try to do, we try to put them with fluids kan. Why? We try to aim a normal blood pressure. Kata blood pressure is about 90 over 60. We are trying to infuse liters of fluids to gain the blood pressure back to 120. So bila kita letak 2 liters of fluids, dia dapat 120 ya. And then kita gembira lah. Tapi kegembiraan ini hanyalah buat sementara waktu. Then what we realize subsequently is that the blood pressure will drop, the abdomen will distend, and the patient will die in coagulopathy. It's because that was probably not the best strategy to approach. Damage control resuscitation is the total opposite. So the concept is maintain permissive pressure. Yeah, you just target a pressure because the higher your pressure, the more you're going to bleed, isn't it? So you maintain a permissive pressure of about 80 to 90 systolic, yeah, until you can buy time. And when your pressures are low, you transfuse bloods early, and the bloods that you transfuse are in combination of packed cells sahaja. Darah-darah kuning, fibrinogens, platelets, fresh frozen plasmas which contain a lot of coagulation factors. You combine all this, so whatever clot that is being forming will be a stronger clot, and that can stop the bleed. This buys you enough time for definitive care. Or in some cases, actually, buys you enough time, sometimes the patient can be managed conservative juga sebenarnya. So these are the concept. So walaupun your monitor is a bit scary in the start, so your BP is just a bit low, but the patient will survive better. So this is a concept of it. You look at these two tabs. Kalau you buka besar, dia laju lah kan, habis kan. Kalau you buka kecil, it goes slow. So this basically in a nutshell the concept of damage control resuscitation. So a few outcomes on the damage control resuscitation is, one of it is hemorrhage control. Whatever you have, the first patient, control the hemorrhage. Kita diajar dulu apa? A, B, C, D kan. But the world today, if you Google pun you akan nampak. Sebelum ABC dalam trauma ada apa? Ada C kecil kan? Dalam that semicolon. That is circulation. Identification and the address of exsanguinating hemorrhage. Kalau contoh, you dapat patient masuk masa trauma reception, you have a bleeding from the base of the neck. Berdarah macam tu. Adakah kita still nak tengok AB dulu, baru pergi ke breathing ventilation kan? To stop that, you compress that first, right? So that is the management of the C in the colon, yeah? Control of exsanguinating hemorrhage, then you go to the A, B, C, D, E, yeah? And that's a little bit of a drastic change. And this change actually originated from the military. In the military, it was never A, B, C, D before. It was always C, A, B, C, D. In the civilian population only, it was A, B, C, D. But today, we are adopting the military strategies, yeah? Because the war is actually on the streets, yeah? Today. Dulu kita kata jangan guna tourniquet, kan? Kalau guna tourniquet, arterial tourniquet lah, tangan akan mati. Kalau bleeding, kita buat point compression, proximal. Kalau bleeding dekat dorsalis pedis, kita pressure on our popliteal artery or our femoral artery. And that was the concept that was put in. Please, we have to put away this concept because our legs got so, our upper limbs especially, got so many collaterals. You block one artery highway kecil buka. They bypass where you compress and they go and bleed back again distally. Yeah? So the upper limbs take about 45 seconds before it rebleeds. The lower limbs about 60 seconds to 90 seconds. Dia akan bleed balik. So the level 1 evidence today is still to use, I don't know whether you can read this, tapi tak apa, nanti dia ambil slide. It's a 1B evidence, the use of arterial tourniquets bag. Ini bukan arterial tourniquet, this is the venous tourniquet. Don't use this one, use this one. This one use first. Direct compression dulu, jangan terus tourniquet kan. So kalau bleeding, try compression first. And that's also a level 1 evidence. I don't understand why compression must be put into evidence, but for some reason, it's still a level 1 evidence lah. Lepas habis, we recommend local compression to limit life-threatening injury, grade 1A. Mestilah grade 1A kan. So it's mostly is common sense, but otherwise is for purpose of documentation. These are the arterial tourniquets that we talk about. Pernah lihat kan ni? One of the models. This is CAT, CAT CAT arterial tourniquet. Sesuai digunakan dalam kawasan out of hospital dan sebagainya. So always use a tourniquet proximal to the bleeding area, as close as you can. Sebab whatever is after that tourniquet is not going to get perfusion. And do not forget to put down the time. In our setting, we try to limit below 2 hours. Yeah? After 2 hours, within that 2 hours, we must get some form of definitive control of that distal hemorrhage. Sometimes you will find and wonder why are there two colors. Dia ada warna hitam, dia ada warna orange. Okay. This again goes back to the military and civilian. Kalau in the jungle, masa you ada warfare, the last thing you want to use is a orange tourniquet, kan? Musuh nampak dari jauh, happy kan? Tahu dah musuh kena tembak kan? So don't use this in the military. So military is usually black color. But in the civilian population, we want to highlight there is a tourniquet. So that's why it's fluorescent orange. Yeah? So that's just the difference. Both of them function the same. Kalau you tak ada sangatlah tourniquet kan, kita selalu boleh gunalah arterial BP, hypomanometer cuff lah. But of course, the best thing to use is portable arterial tourniquet. You can get it into your emergency department, portable arterial tourniquet. I like to share a story with you, kegunaan tourniquet ni. So it was somewhere in 2016. And there was a bridge that collapsed dekat Kuala Lumpur, kat Mid Valley. So it was lunchtime and there was a lot of workers. So bila jambatan yang tengah bina tu collapse, bagus sebab tengah line ramai tak ada. Tapi ada yang kerja kuat tu kena hempak. So moral of the story, jangan kerja kuat. Lunchtime, pergi makan lunch. So bangunan ni dia just bos tak ada, so I katalah kan. Oh, ada video, lupa. Anyway, so bila bangunan ni jatuh, so there was one of the patients, that is ni yang pakai helmet dia ada ni, pointer yang ni. Yang ni bukan mangsa. Ini mangsa ya juga sebenarnya. Ini saya lah. So I'm looking down. The patient ada bawah ni. I'm looking down into this dark hole like my future gelap kan. And this is the patient dalam. Dia memang teruk lah tempat ni sebab dia macam gempa bumi sikit . And that area we had to, the bomba try to extricate but they cannot take the patient out. So about for a good 4 hours. So dia ada bleeding. So patient was a bit hypotensive as well. Bleeding daripada distal limb tu lah. So they tarik patient tu but still they cannot assess the patient. So this is the hydraulic that basically is saving all our rescuers' life lah. Hydraulic ni pecah, semua lah pecah. So can you see my little hand there? I put a tourniquet above the knee, just above the knee. And so instead of doing amputation, we do a disarticulation. So of course, we cannot do this masa hidup lah kan. So we have to give him some procedural sedation, ketamine, balance his pressure, and in a sitting up position. This is a video lah, boleh try main tak? So as we put a proximal tourniquet, because if we disarticulate the leg, can you imagine the popliteal artery is just going to bleed off to death and the patient's in a gravity position? So this is out of the hospital, and this is part of what we call retrieval life-saving amputation. So you need to amputate the patient, and therefore you can retrieve the patient out. So the patient has been amputated, and we managed to retrieve the patient out, stabilize the patient, secure the hemorrhage, and bring to the hospital. So the patient was discharged after 5 days later with a refashion above knee amputation. Right. So this is the stump. Ini masa hantar kat Universiti Malaya Hospital lah. Stump ni dia ada makeshift tourniquet. So dia tak ada tourniquet yang cat tourniquet tadi tu. So I pun terpaksa lah cari arm sling tu, cari kayu satu. Kesian ya. Then we have to wrap it around the supra above the knee region lah. To stop that bleeding. So as you can see, the uses of tourniquet is not just to control hemorrhage, but again, it's to actually facilitate life-saving retrieval amputations. Yeah? Hemorrhage. How do we stop hemorrhage? We have always been using gauze dan sebagainya. But there are a lot of adjuncts that you can use. Many of them are cytokine-based. Many of them are kaolin-based. You can go into the details of them. But generally, these are medically commercial products that are embedded into your gauze today. So if you have a bleed, all you need to do is press, compress it, or pack it into the wound. Kata gaping wound yang besar dekat junctional area kan. Kata contohnya you have a large groin wound. You nak tourniquet kat mana? Pelvis. You know, so tourniquet. There's nothing to tourniquet, isn't it? So you need to do a packing. So you can use certain products which already embed with hemostatics. They promote the coagulation. So you pack it inside there, you can do a hemostatic suture on top of it, or you can even just do a circumferential compression, and you will have effective control of hemorrhage, not definitive, but control of the hemorrhage until definitive care can take over. Yeah? And that is the real life-saving procedure. So for example, this wound, it's not my picture. I mean, it's not our picture, it's a picture I adopt from somewhere else. So this is a way how they pack the wound with certain commercial products into the wound. They control the hemorrhage and do a circumferential compression. In our center, we try to use instead of circumferential compression, because when you circumferential compression, the venous return pun tergendala, betul tak? So what we do is we do local interlocking sutures. We keep the pack in and we do local interlocking sutures. So the venous return still happens well with the other collaterals. Yeah? So it's better perfusion, better control of hemorrhage. So pernah sekali dulu I dijemput pergi ke tentera buat training lah. Tentera buat training very interesting. I share you story. Kalau kita nak buat animal study macam mana? Kita kena minta kelulusan dari veterina, daripada ethics, Jabatan Perdana Menteri, semua. Lepas tu semua kata tak boleh kan. Tapi tentera senang. Dia kata tak apa. Bawa kambing ni, kita jangan bagi tahu siapa, bubuh dalam kiam tentera, kita tidurkan kambing tu, terus kita buat. So that is their ethics approval lah. 1 year before that, they tried to simulate a goat. They want to simulate hemorrhage and how to stop the bleeding. So they decided to shoot the goat. Bila they shot the goat mati terus. So the following year, decided that this video don't show to the army. Okay. Following year, they decided we go slow. What we do, we induce the bleed. So that was the year I was invited. So this is my first time too. So I take a goat, me and my colleague. My colleague is a general surgeon army, major, and I'm the civilian lah. So we identify dengan ultrasound mana dia punya femoral artery. Have you found a goat's femoral artery before? First you must ask which is the leg and the hand. So the back hind leg we anggap femoral artery lah. Kita cari ke dissect. Then I dapat the artery in our hand kan. So we cut the artery. So it starts to bleed. The goat is cataminized. How they cataminize, I will not explain to you. It's extremely vivid. So the goat is asleep, but it's alive. And we put in this product. This is called Silox. Some of you will be quite familiar with it. It's actually chitosan-based gel. So one is powdered form, one is compressed. So I put the one embedded in the gauze. My colleague just throw the powder macam tu. And this is the one embedded in the gauze. Nampak I dah pack dah after 3 minutes. And that's an arterial bleed tau. Dia macam pipe. And we take out this gauze and it's just controlled hemorrhage. It's just pure hemostasis. And I got a shock myself. I didn't believe in this usage of chitosan very much, you know, at that juncture lah. So I really didn't expect the goat to. I expected the goat to die there and then, but the goat didn't. He survive for a while. Lepas tu dia jadi gulai malam tu. Kesian. So army. So we use this a lot in the civilian population as well. And this is one of my patients. Degloving injury, zone 1, 2, 3 of the neck. So it's just bleeding away. So I then after that I start using a lot of chitosan based products lah. So I chitosan kan dia. Chitosan ni dia clamp part of sheep clamps. So they with a lot of different gauze, pack. And if you can see this, the hemorrhage is controlled. Once we stop the hemorrhage, we pack, and then ENT can take to OT and they can take their time rather than the patient dies that way. Yeah. So it's a good hemorrhage control. And these are the other products which you can use similarly to put laryngeal packing, ENT packing dan sebagainya. It stops the bleed. This is my colleague Dr. Rosman. He's doing a laryngeal packing. Dia ada di sini dengan kita. Mana Dr. Rosman? How are you? Dr. Rosman. I share you another story. This patient, dia 60 lebih tahun. So, dia datang kat hospital. So, dia buat grinder tau. Dia ambil grinder ni. Dia drilling. The grinder tu yang kita tu pecah. So, bila pecah, part of it went into his left clavicle. This is not the left clavicle. This is the clavicle of some lady I took from the internet. But his left clavicle broke because it's so strong. It penetrated, fractured the clavicle. And behind the clavicle is this structures. You can see there's a subclavian artery and subclavian vein. This artery especially is just 7 inches from the root of the aorta. So can you imagine the pressure? Tinggi. He came in with a blood pressure of 60 systolic. So these patients die most of the time. Because why he die? Because bila panas, dia buang the thing. So bila buang, they just bleed. So it just comes in like that, trying to press. Despite pressing, it still bleeds. Because the pressure is high. So this was the X-ray. Can't see it, but this is fractured there. So I'll share you this story. So what happened? This is my medical officer that time trying to press the bleed down. And that's me at the back there trying to put that powdered version. Remember I told you the kambing one my other colleague used? But I didn't want to throw it in because it will embolize. So we put it in a gauze. Your normal sterile gauze. Because I did see the size of the wound. It's very jagged. So you create that gauze, put the powder in and macam suit bunjut lah. Just I want to make it sound more scientific. So it's hemostatic ball. So it's a video. Can we play this? Boss. Nak main video boleh, boss? So play this video. Okay. So just look at the bleed when it comes. I'm not too sure if you can see it from there. So can you see the pressure? And this is at 70. I upkan sikit lah pressure. I want a bigger room for error. So while we're preparing the hemostatic ball at the back there, and we are going to compress this bleeder. So he's on a bit of ketamine. Sikit ketamine. His systolic pressure is 70 right now. And that's the scientific hemostatic ball. So I put it inside there. That's a piece of clavicle which I couldn't get it away from my side. I pun tak nak potong benda tu at that time. We have to control. This is the inverted C in the colon. Control of exsanguinating hemorrhage. Remember? This is what it is. And after 3 minutes, can we play the other video? This is after 3 minutes of just compression with the product inside too, with the hemostatic inside too. And you attain successful hemostasis. And after that, what you do hemostatic suturing, and then 3 hours later OT panggil sebab they didn't see a need urgency. If he died, I think forensic would have called him in faster. Anyway, keep calm, do damage control, and this is about 5 days later in the ward. He's got no neurological deficit and he's discharged well. So that is the importance of acute hemorrhage control. So we keep on telling ourselves a lot of things, hemorrhage control, hemorrhage control. Important, these are advanced things which are basically basic and we should be doing it a lot. And most of the time, the gap, every time we blame other people, kan? But the gap is actually ourselves. ED lah, ED. I take it that way. We are the ones who should be controlling the hemorrhage effectively so that our surgeon colleagues can do a better job and better outcome. And they can take their time to come and thank us later. This was a patient of mine in Padang Pariaman. Nampak tak ni dia punya, ni betul ni patient ni. Ni betul. Nampak ni cervical collar terbalik. So there was an earthquake there. So we went there. Patient ni tak bukan mangsa earthquake, dia mangsa accident depan kita punya camp. So kita pasang chest tube kat dia dengan this cervical collar. Why I put this camera, this picture is just because basic things like cervical collar we have already got it done. Most our patient yang tak perlu collar pun datang dengan collar. Bagus, alhamdulillah. Put it first, we can take it out later all the time. But this is something we should move away from. We keep on springing that pelvis just to identify is there an unstable pelvic fracture. That pelvis has a sacroiliac junction with a lot of arteries and veins at the back there. Every time you keep on playing with that junction and it moves, it's going to bleed. Houseman datang. Oh, bos, rasa ada apa pelvic spring positif. Betul ke ni? Kau ni mana tahu pelvic spring? Mai aku tunjuk. MO datang, spring betul-betul. No, BP drop down already now 70. Tak apa bagi fluid. Then after that registrar datang. Ya ke? Then pakar datang, betul. EP datang, betul lah. Refer to orthopedic. Ortho pula tak percaya. Registrar datang. 10 times pelvic spring. After that, everyone is convinced. Yalah, betul lah. Pelvic spring positif lah. By that time, the next person doing the spring is the forensic pathologist. Always bind first, yeah? Bind. Don't do this. Don't spring anything. Boleh lah gerak I think jam again. They accidentally spring the computer. Okay, so don't do this. Binder, yeah. Whenever we try to tell people, whenever you collar the hips, collar apa ni, the neck, collar the hips too, yeah. Because especially in patients where we cannot identify there is unstable pelvic fracture. For example, in patients which are unconscious, polytrauma, yeah, multiple injuries. So collar the neck, collar the hips, and then when it comes, we're still going to do a primary X-ray. Do the X-ray. Rule out an unstable, kalau pubic symphysis tak apa. Rule out an unstable pelvic fracture, remove the binder. Only then do a lock roll. Try not to do a lock roll before you rule out an unstable pelvic fracture. Because if there was an unstable pelvic fracture and kita lock roll, can you imagine the whole weight of your body is pivoted onto your pelvis? It's just going to crush in the sacroiliac junction and you bleed. Many of the times, lock roll, habis, BP low, mati kan? So, janganlah lock roll sangat. This is what we call the low-lying fruits lah. Atau dalam pepatah Melayu, buah-buah yang rendah. Kutiplah dulu. Didn't sound very good, isn't it? We keep it English. Low-lying fruits. Okay, this is my patient. My own patient. Bawa by my pre-hospital care team. No binder. Datang. This was his X-ray. After the primary X-ray. Lepas tu BP dah low. Kejar. Alhamdulillah. Tak jumpa forensic pathologist. So we had to do all this later on. So binder should be placed in pre-hospital. Andai kata datang tanpa binder, binder first in your resusc, yeah, and then do what is necessary to remove it. Just like a collar. Patient datang tak ada collar, kita collar dulu kan. Same concept. Okay. So banyak binder ada. Ini one of the binders we are trying to work on for so long. Guna infla fix tapi tak berjaya-jaya lagi ya. We will try to work harder on this. So this is a CT scan of the pelvic fracture patient. So hemostatic resuscitation. So give blood early, but give blood responsibly. Remember, every blood contains the risk of ABO incompatibility. Every blood contains the risk of biohazard. In my hospital saja, the last month, 3 seroconversions. My transfusion specialist come to see me. Dia ada muka dengan frown kan. Dr. Shah, I need to see you for a while. I takut tau bila dia kata macam tu kan. So, we said 3 seroconversions. Last month alone. 1 syphilis, 1 hepatitis, 1 HIV. But then he told me, good news, you didn't transfuse. Semua anesthesia yang transfuse OT. I tak nak kata Alhamdulillah waktu tu, walaupun kan. Tetapi sebab 3 seroconversion is still bad news. It tells you the risk of transfusion. So transfuse responsibly and transfuse well. We talk about massive transfusion protocols. Massive transfusion protocols are important. Transfuse when you need to, and when you need to, transfuse early. Don't delay. But when you don't need to transfuse, don't transfuse. Yeah. There are targets which we'll talk about later. What is the acceptable hemoglobin levels and etc. But in patients which are actively bleeding, don't go on the targets. But that target is going to drop, and it's also a dilutional target. It's lower than what is stated. MTP 1111. I have to finish this fast. So 1111 or targeted MTP. Have you heard of that? Now we are moving a step ahead where we get the blood similarly. Oh, sorry, rosakkan harta benda hospital. We get the blood similarly fast, but we don't do it 1111. Mungkin we only need more fibrinogens than we would need hemoglobins. So we put more cryos, more FFPs, lesser packed cells, but to attain the same amount of volume of blood. 1111 gets you about 750 mils of blood. Yeah? Maybe you want 2.1 liters, but you want more yellow blood than you want red. So now you're able to play the ratio, but get it in the same time. This is what you call targeted MTP, TMTP. And this is going to be new. You don't Google it because it's not non-existent. We're happy to say that this is a guided transfusion. But in order for you to know this, you need to have in your ED point of care test that tells you the INR straight away, tells you the fibrinogen straight away, the hemoglobin, the platelet levels, the base excess, the ABG, the calcium straight away. So the point of care test is important for you to be guided. This is a sneak peek into the 2023 Kementerian Kesihatan guidelines on PBM, patient blood management. So the TMTP will be revealed in the PBM. I letak draft lah sebab it's still draft copy. So this is the MTP and this is the targeted massive transfusion protocol. So there's a big workshop there, a lot of discussion. We managed to push this through and it was endorsed by Blood Bank. So this will be one of the national guidelines, TMTP. Doesn't exist in many other countries as well. So we're happy to say we'll be one of the ones who start this. You need POCT, and this is the POCT that we use in our ED, INR, ABG, FBC. This is the POCT of the future. This is called viscoelastic assays. This tells you everything in one graph. Of course, this is expensive, 500 ringgit per cassette. But this is the reason why a guided transfusion will be done. Only if you have this, it tells you better. But a lot of studies show when you compare traditional point of care, like the ones we use just there and then in a couple of minutes, versus the viscoelastic, the difference is argumentative. Yeah, not many studies on that, but it's quite argumentative. But we conclude that if you have a POCT, it's of course much better. Yeah, right. Always reverse your patient's medications. Cut the patient on warfarin and bleeding. Don't just control the bleeding. Reverse that medication first and also control the bleeding at the same time. Warfarins, for example, do give your, do give your vitamin Ks, yeah, and also your FFPs fast or prothrombin complex concentrates. We carry that in our trauma unit right now. And we use a lot of that in patients, not just on warfarin, but patients who will arrive with early coagulopathy, 20 international units per kilo dose. And it's low volume but high concentration of plasma products. Yeah? So we use that quite a lot. Tranexamic acid, that's another adjunct. That's amazing. Reversals, these are Praxbin for idarosizumab. This is the prothrombin complex that we use, a 3-factor prothrombin complex. And it's a grade 1C recommendation, the routine practice of using point of care to assess your PTT, PT, INR, APTT, or viscoelastic assays at point of arrival of trauma patients. And it's also the volume that you use, but not the volume, what makes the volume. So crystalloids is still the first line, a 1A recommendation, but what type of crystalloids? So in our center, we now use more of balanced solution, sterofundin generally, against normal saline, especially for head injury patients. That's a 1B recommendation. We avoid the use of colloids in active bleeding patients because the colloids are bigger molecules. They stay in your blood vessel. They don't go out, right? So if you have 10% of platelets, for example, you put in a colloid, is it going to be 10% of platelets anymore? It's going to be 8, 6, 5. You're going to dilute that space because colloids don't go out. Your platelets are bleeding out. So as you're diluting your coagulation factors, your platelets, your fibrinogens, so Don't use colloids. Just use crystalloids. Yeah. If the patient is no longer bleeding and there's no coagulopathy, you can use the colloids. Yeah. So that's a 1C recommendation to not use colloids in active bleeding patients. The use of reversals are very high, 1C. In the bleeding trauma patient, the recommendation of emergency reversal with vitamin K and the use of PCC in combination is 1A. Yeah. So I'm just giving you a rough guide. I know it's too academic, but just to say that it's important. Yeah. And higher levels of recommendation. The use of desmopressin. We use this a lot in our center. Number one, in intracranial bleeds where they start passing a lot of urine. So it's a ADH analog, vasopressin analog. So it stops the bleeding in DI, diabetes insipidus patients. And we also use this in bleeding trauma patients because it enhances the activity of your platelets, yeah, by increasing your von Willebrands and factor 8 and blah, blah, blah. So aside, it helps your platelet to bond better, to bind better. So the use of desmopressin is something you can consider. And that's also a 2C recommendation, the use of 0.3 micrograms per kilo in patients which are platelet inhibiting drugs or von Willebrand's disease. The use of calcium, I like to highlight here, is a 1C recommendation now to ensure your calcium is always at a normal. You can either give calcium chloride or calcium gluconate. It's very cheap. Just monitor it. If we don't monitor, we don't know it's normal. Especially when you're transfusing a lot, the chelating agents for calcium drops, keep them up. Calcium is a very important mineral. It helps hemostasis. It helps vasoactive activity in your smooth muscles. It helps cardiac contractility. Yeah? A lot of things it helps out. Right. So the use of cryoprecipitates in trauma is important because it holds fibrinogen. It's fibrinogen rich. Fibrinogen is the end of the game, the last mesh that actually makes that bond, together. Yeah. So it's very important. And this is also what breaks down in your systemic inflammatory response in acute traumatic coagulopathy. The usage of tranexamic acid early, use it in pre-hospital care. So we published a paper. Crash 2 says that tranexamic is very good, you have to use it and blah, blah, blah. It doesn't tell you how to use it in out of hospital. So we published a Malaysian paper, the administration of tranexamic acid in a pre-hospital care service. So how our paramedics can actually give, what cases to give, and etc. And we can download this in the MGEM, Malaysian Journal of Emergency Medicine, on a guideline of administration of early tranexamic acid in trauma patients in Malaysia. So the role of ED, we always give, we said pain is the 5, 6, 7, 10th vital sign dan sebagainya, but how much are we managing the pain? So the use of regional anesthesia today is quite provocative, I would say, but it's something which is good because it helps us, especially in our trauma unit. This bone was actually in the leg and it was just floating around and terribly contaminated. And the bone was jutting out. We had to actually debride that in the ED. And it was only possible to do that in this limb with a femoral block. Yeah. So these are videos, but I won't play it so much. But trust me to say that ultrasound guided, I might can play that then. Ultrasound guided regional anesthesia, where you put the needle right to that nerve and inject very specific chemicals with sodium inhibitors, and you have amazing pain relief. And it helps you to debride the wound better, meaning which lesser subsequent complications from the surgery that takes place. Yeah. And this helps the entire chain of survival for this patient. So consider this a lot. And for you to do this, just get some training. You can. We're happy to accept patients to, accept staff to our centers or attach to a regional anesthetist and get this training. So the trauma physician training does include a lot of this. Yeah. Pen scan. You see movies that you have trauma and then you enter this round tunnel and you get a scan from head to toe. Yeah. So a criteria-based pen scan is important, what we call as a whole body CT pen scan. So Sungai Buloh and Hospital Kuala Lumpur is the first two centers to have the whole body CT pen scan on a criteria-based selection cohort. So now, the outcome of your trauma patient is no longer dependent on who is the doctor working on the shift. Bagus ke, tak tidur malam ke, dan sebagainya. But it has to go to how advanced nations do. It has to be system-dependent outcomes rather than individual-dependent outcomes. And this is the leap that we have to take in trauma care for the future. One of the systems that incorporate that is the whole body PET CT. If you fit certain criteria, you get a whole body PET CT, there's no more surprises after. You will know every injury that there is there. If the blood pressure goes down, you know exactly from where or from where not. You avoid unnecessary surgeries. You will conduct procedures which you were taught otherwise it shouldn't be done. With this alone, our chest tube insertion rate in ED has dropped more than 80%. And chest tubes are notorious to cause death actually, when the chest tube itself was never necessary in the first place. So the PAN CTs help a lot. So the radiologists, I tell them, you sit in this dark room, but you're saving lives. You don't know how much you're helping the people out there, you know. And this is what they're doing. They're happy to do that. So this is the MATA's review that endorses the use of PAN CT in Malaysia, so-called the FDA approval equivalent in the US, for the use of CT technology for PAN CT. And these are the criteria. So you can download this in the MGM journal as well and have a go through of it. Yeah. This is the paper. Sorry, this is another paper. This is another story I like to tell you. Patient have concussion, come to ED. Apa kita buat? Tunggu 6 jam, duduk sana. Okay, lepas tu boleh makan, minum. Boleh jalan ke toilet sendiri dan pulang. Very good. GCS full, pulang ke rumah kan? But have you ever come across patients when you ask the patient, you dah cerita, doktor apa jadi? Oh, saya accident dan sebagainya. Sorry lah saya. You accident dan sebagainya, sekarang you dah okay sebab you ada di hospital Sultan Abdul Halim. You dah happy lah. Setengah jam kemudian dia pergi tanya lagi MO you. Doktor apa jadi kat saya? MO pun cerita lah, takut kena marah dengan bos. Tapi staff nurse dah lihat dari tadi ya. Half an hour later dia tanya staff nurse pula. Staff nurse terus label, patient ni saja mengada, saja nak tanya. I mean, we have all come across this. Actually, no. The patient mungkin ada lah juga saja yang mengada. Tapi actually no. The patient is unable to retain new memory. What we call as PTA, post-traumatic amnesia, anterograde amnesia. Not that he forget the past, which comes back very fast, you would realize, but he cannot remember the future. And we discharge this patient because you take GCS at that time. GCS is 15. You discharge dia balik rumah. Balik rumah saja, we write cerebral concussion. Bagi some anesthesia, apa-apa semua. MC sehari setengah, baliklah. Balik rumah, dia pergi kerja. Bos suruh buat ni. Lepas tu setengah jam dia pergi tanya bos, bos, buat apa? Habislah, 2-3 kali jadi macam tu, he loses his job. And cerebral concussion, very benign. Nobody diagnosed him as post-traumatic amnesia. And this is prolonged post-traumatic amnesia. It's actually a moderate traumatic brain injury, no longer mild. And balik rumah, bos tak apa lagi. Balik rumah, wife pula suruh buat kerja. Lepas tu dia buat perangai macam tu habis. That one is catastrophic. So, you can see how the patient swirls out of the society. And a lot of these patients, fortunately or unfortunately, the ED is the last line. Sebab pergi KK tengok discharge summary, cerebral concussion, CT brain pun normal kalau andai kata dibuat. So that's it. That's your death sentence for you. The post-traumatic amnesia assessment, AWPTAS. So this is something that we have replaced as just compared to a normal GCS. Here, the part of the GCS, you are shown 3 photos and you are asked to recall this again. And this assessment is done on a scale basis. So this is called the AWPTAS assessment. It's a verified scoring system. In Malaysia, we modify and tambah the Malay version of certain questions in the verbal component. So these two you can download from the MGEM. So patients are not only assessed on your GCS, but the ability to retain new memory. And if certain memories are not retained by certain period, we give a pie chart when to do the CT scan and what to do after the CT scan. And for you to discharge, the PTA screening test in emergency has to score 18/18. The extra 3 is the 3 photos on top of the 15. So these are the way forwards that we go towards some of the changes that you can easily adopt. Trauma team. There's a lot of talk about trauma team. Everybody who do trauma team, semangat buat trauma team, lepas tu semua turun tengok, lepas tu seminggu dah habis, tak jadi dah. And we wonder why it doesn't work and why the West it works. It's because our system is different. We cannot take what we take from the West and put it in Malaysia and expect it to happen. But what we take in Malaysia, put in the West, it will happen. Not the reverse. So the trauma team is a very important link. Prior to that, everybody in the trauma chain of survival is important. There's nobody more important than the other. The ED is not more important than the 999. Neither the ED is more important than the rehab physician. This chain is important to have the best outcome of patient. And the strength of this chain is only as strong as the weakest link. If your pre-hospital care is weak, the rehab physician has an interest to actually even help that chain improve. Meaning which we have to help each other's department to improve their strength because it will determine our outcomes of the same patient. So it's a whole team process. This is the real trauma team. Activation of trauma team. So when you have a patient coming, you call everybody to come. In the West, dia ada anesthesia yang menjaga airway. EP don't jaga airway sana. In the West, anesthesia. In the UK lah mostly. American system different. Then dia ada nak pasang line. Vascular surgeon pasang line. Not EP pasang line. So they are very, very demarcated. But when that doctor is only working for the trauma call the whole day, so you activate lah 10 kali pun, walaupun only 2 genuine activation, kerja dia datang je. But when you do that in Malaysia, activate, neurosurgeon datang, general surgeon, orthopedic, EP datang. Lepas tu, okay, ortho datang, first time, ini isolated brain injury. I balik sambung my clinic. Kali kedua dia datang. Kali ketiga dia hantar registrar. Kali keempat, registrar pun dah fed up, hantar MO. At the end, is the biggest houseman activation trauma team, in the hospital. Semua houseman datang from all the departments. And it beats the entire purpose because it's not the decision makers. Yeah? The idea of the trauma team is to have early, fast decisions and planning. Kan? So all the housemen go back and talk to their boss again. Then the boss datang. Repeat pelvic spring. Sekali lagi. Hence, it fails in this country. Yeah? So a two-tier trauma team activation. The real trauma team is apa sebenarnya? Nak jaga airway, breathing, circulation, is ED. We are the first tier trauma team. And when you do your primary survey, secondary survey, you will start identifying what are the injuries that are actually required for another specialty to come now and do an immediate laparotomy, immediate exfix. That is the tier 2 activation. Then you activate the surgeon. So nobody cries wolf anymore. Kalau ED panggil, memang datang surgeon je. Because they know it's not something out. If it's an indicated call. This is what we practice in Sungai Buloh. So when we call, we come. So the laparotomy is actually done in the DCR suite, dalam ED itself. And this is the trauma team outcomes that we get in the Western world, but differently implemented in our country. Yeah? So all the outcome shows there's no outcome that says trauma team reduces or increase mortality lah. Everything reduce mortality. To achieve these three things: rapid horizontal approach, accelerated decision making, effective interspecialty team. Having the same outcomes, re-strategize to implement in this country. This is not only trauma team, but almost every system that we will learn from the West. This is the West. Tengok siapa ni, NS lah, surgeon lah, nurse 2, nurse 3. Sorry, minta maaf. Tuan, berapa minit lagi ada? Tak ada. 5 minutes. Okay, I'll rush really fast. Okay. See how fast I'm rushing? Okay. Pre-hospital notification. Before the patient come, so we have to have an app system, and this is what we do, is a Google Form system, murah kan, murah. So we get to know not only a patient is coming, we get to know what patient is coming. Umur berapa lebih kurang, the pre-hospital will send to our app. So we can prepare, so for a very good trauma reception. So our team, this is our DCR suite. So we always say that we have to prepare for trauma reception, but this is not the way to prepare. Nampak, ini pun my unit juga ni. Banyak sangat orang, but nobody can see the patient also. Don't know what's going on. But this one, tengok orang kurang tapi ada sistem. So this is what we want. So less can be more to have an effective trauma reception. Trauma reception is when you come in and do the handover, and you're prepared for the system. So this is a bit on the damage control resuscitation. This is a video. When you have a system, I share another story. 14-year-old boy, dia kena langgar dengan lori one time. Dia about 45 minutes away from the hospital. Di sana ada one Mahamas ambulance. Cepat masukkan dia, bawa ke dalam hospital, terus datang kat kita. Patient ni 14 tahun, collapse depan triage. Sebab dia kata lambat sangat nak tengok patient, dia collapse. Tak ada air gurau saja. So he so happen what we call as traumatic witness arrest. Sampai depan triage, collapse. Straight bawa to the DCR. So he had a tire mark on the chest. So we do a bilateral finger tracheostomy to decompress the chest. That's the trauma protocol. You make macam chest tube, but you just don't put your tube. You just decompress both sides. No questions asked. No need to know anything. Traumatic arrest, suspect chest injury. make 2 holes, decompress. So any pneumothorax tension tak payah nak diagnose. Ada, dia akan keluar. Continue the CPR. 1 minute, second minute, we open the chest. Oh, sorry. We go into the heart. Cardiac massage, release of tamponade, control of hemorrhage. Get the return of spontaneous circulation, close back the chest, definitive team come and take over, do the repair. So this is that 14-year-old boy on the right. Boleh main video? Dah makan breakfast. So this is resuscitative thoracotomy in our center. This is done by the trauma physicians. So it's the ED that does this. Boleh main semua video ada serentak this one. Okay. So this is the clamp, the vascular clamp, because there was a large bleeding from the perihyla. So I managed to clamp that. We get the heart pumping again, and we do a lot of packing to stop this one. Lepas tu sebelum kita keluar, we do a washout. After we wash out, and then we show that the blood pressure is running. So this is actually ACLS in a different level. So while you're doing the procedure, you're actually running adrenaline at the back end, your magnesium sulfate, sodium bicarbs and all that. So it's ACLS, but you're not doing external compression, you're doing direct massage. And that hemorrhage, one of the causes of hemorrhage, the H's and T's, you're actually controlling it literally yourself. And you get this patient to have a blood pressure of 90/60 back, pupils bilaterally reactive. The cardiothoracic team comes in and does the repair. So this is after resuscitative thoracotomy. We leave the clamp there, and the next team takes over as part of the trauma chain of survival. The national trauma policy, which we are waiting for to come, will empower the chain of survival. And you can imagine now, just at this level of the lecture towards the end, how important and the role that you play in the context of the trauma moulage competition. I'll run this quick. Sending the patient no longer to the most nearest hospital anymore. Sending to the patient to the nearest most appropriate hospital. Little study that we did to take that patient from that small hospital with no neurosurgical facilities to the neurophysical facilities, which is 15 minutes apart, takes 8 hours at average. Tak payah buat apa pula, the brain is gone. So spend an extra 15 minutes, transfer the patient to the most appropriate facility. Having governance, having quality audit processes is important. Having multi-pronged trauma training, not just specialists, MO, MA, staff nurse, PPK even. So a 4-pronged system which we start. This is our ADAC training process that we train. These are the nurses that in the DCR suite, so they have an observer area, so they get involved in the training. This is the National Trauma Life Support Roadshow. Getting all the trauma life support to be standardized. Kalau tak, air keruh berbeza dengan banting dan sebagainya. So having one syllabus, doing a national roadshow, we are training. So Kedah was actually the launch. Okay, minta maaf abang, sorry. Okay. So you see how far I'm running. Right, laju. Okay. So trauma training program. You can send your pakas to us kat Sungai Buloh Hospital for a 3 months attachment, and we will give you a short special interest group training. And if you're a bit more enthusiastic, please join the subspecialty trauma fusion program. It's only 3 years. Apply at the HLP. Minimum 3 years. 3 years lah. Most by 4 years dah pass. Keluar. Okay. And Sungai Buloh in our center is a training center. This is a free access Prescott Trauma Series, CME, every month. Please join. Feel free. It's free. No harm. Malaysian Trauma Registry. Data is important. We are recruiting more and more centers. We have 27 in the country now. We invite all hospitals in the country to contribute to data. So we have our local data. So we have eyes and ears to the future. The future is actually important because it is very much going to be a structure-based, system-based clinical approach. All the 3 needs to be developed. I share a little bit of photos of the DCR suite. You need a process that mirrors, a service that mirrors, as infrastructure that mirrors your service. An infrastructure that tallies to how you work. Proper lighting area, ultrasound in situ on the pendulum, bloods in situ, drugs, medications, ergonomics in resuscitation. Then you have good outcomes. We're happy to say we won the Anugerah Inovasi 2020 Kementerian Kesihatan. And this is the future, a hybrid suite. The hybrid suite has not just damage control resuscitation, damage control surgery, but also IR facilities. And this is Fasa 3 RMK 13 project for Sungai Buloh. This is the future, ladies and gentlemen. It's 5G. It's inevitable. If you do not know how to use the computer, start learning now. Because whatever that we do and improve or services that we put into traumatology have to take this into account. Getting information technology and AI, artificial intelligence into the service. Cloud-based data services, online encrypted consultation. You don't have to be there anymore. Seeing your patients from a distance in your ambulance, giving diagnosis, having machines tell you the diagnosis, radiologist CT scan telling you what's the diagnosis immediately, more accurate than a human diagnostic ability. AI guided trauma reception and resuscitation. Can you believe? Can an artificial robot tell you how to resuscitate a patient? I come from a center where more than 10 years ago, if I can move this forward, just a small video at the Alfred to play. They created a software where with all the information that's put inside, the software now tells you what to do. And when the nurse keys in blood pressure, how much, the data comes in. As the data comes in, mechanism, trauma, chest rise, the machine tells you, consider pneumothorax, consider left chest tube, consider hypovolemia for retroperitoneal injuries. So we can play that video. Trauma patients at the Alfred Hospital are said to benefit from a world-first trial of computerized super screens, which guide doctors as they treat life-threatening injuries. This is called the TRR system. This, ladies and gentlemen, is going to be the future of the world. Either we hop on it and join, or we just keep on watching videos of them doing this. Yeah? And whatever that you do today, it has to be an IT-based system. And we are starting because we have ambulance in the private sectors moving towards this. And we need to move towards this fast. We are always 30 years late as compared to the Western world. And I hope that gap can be narrowed. I played to you a DCR service suite just before we close this. And this is the infrastructure. We welcome everybody to come and, to come and visit our infrastructure service. Come and join us. Come and spend some time with us, work together with us. And we can share with you our system, our clinical approach, and also the infrastructure. So it's a one-stop infrastructure that contains everything there. Nobody needs to leave that room, and the entire closed-loop communication is kept for the patient's resuscitation. Every emergency department has an operation theatre attached to it, actually. Unfortunately, it's never used for this purpose. Always used as an OPD, outpatient care, and etc. It's time that emergency services start using what the OT is there for, actually, as a damage control resuscitation suite. And this is what we did in Sungai Buloh, actually. This was a storeroom, if you believe it or not. Sebelum lah. Lepas saya kena marah banyak tau nak buat benda ni. Tak apalah. So the entire, if you can see, the ultrasound is even on the pendulum. Tak perlu nak tunggu ultrasound datang lambat sebab you need to repeat 2-3 times. And it's also a training center, so you got a lot of screens you can see. The screens is for the observer, so they don't need to come into the patient. They can see it from their from their demarcated areas. Remember, the infrastructure needs to mirror your service. Yeah? This is the PAN CT system. Patient is taken out, the PAN CT is at the back. And after the DCR suites, patients are stabilized, they go into a 4 dedicated step-down trauma bed, yeah, in the trauma system service. From there, they go to the ward, ICU, or if you need some form of surgery, or etc. And if a surgery is done and you're unstable enough to go to a GOT, that surgery is done in that DCR suite itself. We have, I think, about 9 laparotomies and 2 exfix done already. The trauma moulage competition is going to be something great. I wish all of you the best of luck, and I hope I am able to share a little bit of some of the experience to provide you some spiritual motivation for your competition to come. I thank the organizers from Hospital Sultan Abdul Halim, Puan Pengarah Dr. Zainal, and Kepala Pengarah for having us here. And ladies and gentlemen, all the best and thank you very much. Sorry, lambat. Extra time.
Kami mengucapkan
Oh yeah, thank you so much.
Bukan urus kalian ini petikannya kan?
Dengan penuh besar hati, Majlis dengan ini mengucapkan selamat datang kepada pengarah Hospital Sultan Abdul Halim, Dr. Fauziah Abdul Wahab, diiringi timbalan pengarah 1 Dr. Muhammad Ali bin Muhammad Nadar Khan yang menyertai kita ke Dewan sebentar tadi.
Kemudian hadirin semua, mohon diri untuk menyanyikan lagu Beraku dan lagu JKM.
Panggil lain, panggil lain buat promo kos. Kita panggil lain, promo kos, promo kos.
Promo kos. Okay.
Tuan Abdul Halim, yang dihormati Dr. Syah Jahan dan Dr. Syah Jahan Bismillahirrahmanirrahim. Alhamdulillah rabbil alamin. Wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa sahbihi wa sallam. Allahumma ij'al jam'ana hadza jam'an mubarakan marhuma wa tafarruqana min ba'dihi tafarruqan ma'suma wa la taj'alna nuqma fina wa la ma'ana wa la man yatba'una syaqiyyan wa la mahrudan wa la mahruma. Ya Allah, ya Rahman, ya Rahim, hanya padamu sahaja kami panjatkan kesyukuran atas segala rahmat dan berkat-Mu. Sesungguhnya kami berhimpun pada hari ini bagi menyatakan kesyukuran di atas kurnia-Mu yang tidak ternilai. Jadikanlah kami hamba-hamba-Mu yang sentiasa bersyukur, sama ada nikmat yang sedikit dan lebih lagi nikmat yang berkuah kepada kami. Kami memohon kepada-Mu agar Engkau berkati Ceramah Moulage Championship 2023 ini dengan dilaksanakan dengan lancar dan jayanya. Dengan majlis hari ini juga kami memohon inayah Mu kepada kami. Dalam hati-hati kami, lapangkanlah dada kami supaya kami dapat mengisi ilmu dan pengetahuan yang berguna. Sesungguhnya ya Allah, pada hari ini kami dan hamba-Mu yang bekerja bersama-sama bagi menyelamatkan nyawa dan kesihatan insan lain. Muliakanlah kami dengan ketakwaan, sifat rendah diri, serta kekayaan ilmu pengetahuan. Ya Allah, kesihatan anggota, kecerdasan minda, ketenangan jiwa, serta kekuatan semangat. Jadi kalau kami insan yang terus komited dalam melaksanakan tugas-tugas dengan cemerlang dan berkualiti, semoga dengannya kami mampu mendepani cabaran, berdaya saing dan mampu mengangkat martabat diri. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Wa sallallahu ala sayyidina Muhammad wa ala alihi wa sahbihi walhamdulillahi rabbil alamin. Terima kasih diucapkan kepada Dr. Yusri atas bacaan doa kita tadi. Sekali lagi, selamat datang diucapkan kepada semua ke program Northern Region Ceramah Moulage Championship 3 tahun 2023. Program ini adalah acara berkala anjuran jabatan dan peserta kecemasan Hospital Sultan Abu Halim diadakan bagi liputan kawasan utara Malaysia merangkumi seluruh negeri Kedah, Pulau Pinang dan Perlis.
Ianya bermula pada tahun 2016 dengan aspirasi untuk meningkatkan kompetensi dan keyakinan dalam trauma resuscitation di kalangan staf kecemasan, terutamanya di hospital atau klinik yang tidak mempunyai bidang kebakaran. Kemudian ianya diteruskan pada tahun 2018 dengan membawa aspirasi dan agenda yang sama. Namun setelah kita dilanda pandemik COVID-19 pada tahun 2020, program ini berehat selama 4 tahun. Dan kini ia yang dilaksanakan kembali pada tahun ini.
Tidak boleh jika ada alu, tiada resumnya, tidak berguna dayung tanpa perahunya, tidak berkat ilmu tanpa amalnya, tidak lengkapkan majlis jika tidak ada yang berbicara. Seterusnya diberikan dengan ucapan haluan daripada Dr. Bayan Abidin selaku Ketua Jabatan Kecemasan Hospital Sultan Abdul Aziz.
Next stand lah. Announcement, extend lah.
Bagi
Saya minta kebenaran untuk extend.
bagi memberikan kata-kata haluan dan semangat kepada para peserta dengan segala hormat yang dijemput.
Allah. Okay. Assalamualaikum dan selamat pagi. Terima kasih Tuan-Puan Pengurusi Majlis. Tuan Pengurusi Majlis, dia extend 3 bulan lah. Kalau boleh 6 bulan, MO pun tak cukup. Boleh. Apa saya pegang kot. Yang berbahagia Dr. Fazal binti Abdul Wahab, Pengarah Hospital Sultan Abdul Halim. Yang dihormati jemputan hormat, saya jemput Dr. Fatahul Laham, Ketua Perkhidmatan Kecemasan Kedah, tapi beliau dapat hadir hari ini dan mungkin akan bersama kita esok hari. Yang dijemput khas jauh dari Hospital Sungai Buloh, Dr. Shah Jahan Mahmud Yusof, Consultant Trauma Physician dari Jabatan Kecemasan Hospital Sungai Buloh. Saya kenal Dr. Shah Jahan ni dari asal lebih dan more than 16-17 years lah, dari hingusan MO. Sekarang hidung sebagai hidung mancung di Hospital Sungai Buloh. Tapi saya rasa saya kena jemput Dr. Shah Jahan specially for trauma course lah. Sebab selepas mendengar lecture Dr. Shah Jahan tadi, saya ada post lecture amnesia. Dia tak boleh retain terlalu banyak, 170 slide. So saya minta maaf, saya tak sejemput lagi Dr. Shah Jahan. Kita bayar dengan sebiji bilik di Cinta Sayang saja. Yang dihormati pakar-pakar pelbagai perubatan, penolong-pelbagai perubatan, staff nurse dan barisan sekretariat saya yang diketuai oleh Dr. Beh. Terima kasih sekali lagi. Saya ingin mengalukan pada siapa yang datang luar pada kesempatan ini, saya mengalukan keadaan tuan-tuan dan puan-puan di daerah Kuala Muda, specifically di Hospital Sultan Abdul Halim. Saya diberi saya diberi 2-3 page saja bercakap hari ini Dr. Fazia. Dan dia namakan melirik-lirik, tapi saya tak rasa melirik-lirik jugalah. Ini adalah our third Northern Trauma Moulage competition. Kita tertangguh lebih 5 tahun. The last is 2018 dan kita hopefully kita boleh restart balik. Kita buat every 2 years. Hopefully kita will menaikkan semangat kecintaan untuk merawat pesakit trauma. Trauma is very difficult disease to manage lah sebenarnya. Tapi with a lot of effort from everybody. Sekarang ni starting from you all lah. The most frontliner, the MA, the staff nurse, the MO, the pakar, to manage the early phase of trauma is very important. So that's we want to improve. Jangan risau pun menang sampai kalah. Yang penting sekali ialah the experience, the knowledge. That's why we especially hari ini kita buat ada sedikit lecture by our very renowned Malaysian renowned lah, at least Malaysian renowned trauma expert. Dan kemudian kita buat skill station dan tomorrow kita bergembira sedikit lah for the whole day. Don't worry, kita tidak akan penalize macam kita punya tuan musim majlis hari, kita tak akan extend 3 bulan. Don't worry. Sorry lah, for the next 2 days ni saya akan kacau dia lah. Saya akan extend supaya dia boleh terima dan mindset dia akan di extend. Saya tak mau bercakap panjang sebab saya rasa kita dah kehilangan banyak waktu sebab kita tak berikan waktu tu pada Dr. Shah Jahan. Saya ucapkan terima kasih sekali lagi Dr. Shah Jahan kerana sudi meluangkan masa dengan tim dia dengan Dr. Shah Jahan, Dr. Rosman. Dr. Rosman pun dulu pun MO di sini, dulu bekerja di MO Langkawi, kemudian bersama belajar sebagai MMed, Miss Medicine dan kemudian jadi trauma physician dan bekerja di Sungai Buloh. Dan saya ucapkan sekali terima kasih kepada Dr. Beh and the team kerana well done, well run and well did. And last and not least, masa dulu Dr. Fauzah datang, kita buka dengan khusus BC. Tahun ni Dr. Fauzah, saya ucapkan tahniah sekali lagi kenaikan pangkat Dr. Fauzah sebagai Jusasi. Saya harap dia dapat meneruskan kehebatan beliau di kawasan Buloh. Sorry, hospital Ceramah Bahaya, sorry. Jauh saya transfer Dr. Fauziah ya. Saya pun extend. So, Dr. Fauziah di hostel Istana Bahaya. Okay. Tapi saya rasa Dr. Fauziah akan lebih hebat lagi kalau Dr. Fauziah boleh tarik jusasi itu di hostel Ustaz Halim lah. Sebab saya rasa banyak kerja Dr. Fauziah tak habis lagi ni. Saya tengah buat checklist ni. Dr. Fauziah tak selesai ni. Terutama akreditasi dah. Dr. Fauziah pun dalam program dah jadi surveyor kan. Jadi Dr. Fauziah mungkin nak tengok performance Ustaz Abdul Halim lah. Saya ucapkan sekali lagi welcome to Third Northern Trauma Moulage. I hope you all enjoy. Saya diberi pantun tapi saya tak payah pantun lah. Saya kasih pada Dr. Fauziah pantun pula lah. Okay, saya ucapkan sekali lagi selamat datang dan enjoy your competition tomorrow. So, terima kasih.
Otherwise I have to follow him back.
Sungai Buloh pun tak ada pengarah lagi ni.
Tak ada.
Memang masih menunggu lagi.
Pos apa Jusat
C lah. But could this pension on B.
Oh, pension B.
Dan seterusnya merasmikan Northern Region Trauma Moulage Championship yang ketiga. Majlis mempersilakan. Bismillahirrahmanirrahim. Terima kasih pengacara majlis. Yang berbahagia Dr. Zainal Effendi bin Zainal Abidin, Ketua Jabatan Kecemasan Trauma Heksa. Yang dihormati jemputan terhormat Dr. Fatahul Laham, Pak Ismail Alam today. Yang dihormati, I want to say yang dikasihi, because his lecture was so superb just now. Dr. Shah Jahan Muhammad Yusof, Pakar Politik Perubatan Trauma Jabatan Kecemasan dan Trauma Hospital Sungai Buloh. Yang dihormati pakar-pakar, barisan fasilitator dan setia, dan juga semua para hadirin sekalian. Welcome to you. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Kedah sejahtera nikmat untuk semua. I'm also given few pages to read here, but I don't think I will go through in that detail. But what I would like to tell you today is it is my day to report duty, Right? So I've got very mixed feeling actually. But I always thank Allah for giving me the opportunity to work with everyone. And I think I have a wonderful group here in Heksa. And also today, with all of you, I think from the 23 components from all over Malaysia. Alright? Yes. And I think there are also participants from Sarikhe.
Yes.
Right? So welcome to all of you. And just all of you that have to eat in order to live here. I would like to mention here, I enjoyed Dr. Shah Jahan's lecture just now. Thank God I came a bit early, right? Because I love to listen to clinical updates
Dia
and
sebagai pengarah di
improvement
NS
for
SMO.
patient care. Because I think whether you come from pengurusan, you come from any area of the health system, you are here for the patients. And we must get the, like he said just now, you have to have a proper system, not only having proper MO ada di sana, proper PPK ada di sana, but the system is not in place. So we have to get it to that extent for Malaysia, and I pray that we will go forward for improvement of this country and for the well-being of this nation, right? So I will not go into so many details. I think basically all the reasons why you are here. It's like addressing all the trauma issues that come. I'm from anesthesia actually previously, and once the ED calls you, your heart is beating fast. I can see the challenges more when I became a pengarah hospital because I come in as a primary unit before. So maybe my view of looking at things at ED was different. But when I became a pengarah hospital, I really went down to ED first to sit down and see why ED has so many complaints. What's the problem, right? I'm going to be with them. I'm not going to talk bad about them. I'm going to be with them and see what is their difficulties. I learned a lot. And ED has been my favorite department since I became pengarah from 2014. So electricity tertinggi adalah untuk ED physician di hospital. Setiap tahun, right? So I'm not biased towards anesthesia. I just want to say that. So I hope that today and tomorrow you'll have a good time here, and the competition will go on well, inshallah, and you will learn a lot. And I think there will be a lot of simulations as well, and that you can practice back in the real clinical area, inshallah. Okay. I wish you all the best, and hope to see all of you again. And I need to make a mistake, so I'll be extended here. Okay, so I think we have lovely people in Hissa, but I think I will have another platform, to address all of you before I go. And I would have a pantun actually. Alright, so nak nyanyi tak boleh nak nyanyi sebab saya tak tahu lagu drama. Alright, so but I can sing for you a simple song. Like maybe it's okay. It's old, but it's gold, right? And I think it's evergreen. Just a few lines, okay? Roses are red, my love. Violets are blue. Sugar is sweet, my love, but not as sweet as you. On graduation day,
Orang nyanyi lah.
you handed me the note.
Bayu.
I signed these big roses are red, my love. Violets are blue. Sugar is sweet, my love, but not as sweet as you.
Kau kena ajak karaoke ya.
Saya merasmikan Ceramah Moulage Championship Northern Region 2023 edisi ketiga. Saya sudahi, wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Terima kasih.
Excellent.
Seorang
First time saya dengar pengarang nyanyi.
sang to the whole Malaysia.
Sekarang kena ada sambung lah tu. Print the diamond. Yeah, delete export. Betul.
Bagi kenang-kenangan, majlis telah segala hormatnya menjemput Dr. Fauzia bagi menyampaikan token apresiasi kepada Dr. Syahzahan atas kesediaannya datang sekedar bersama dengan program kita pada kali ini. Majlis mempersilakan.
Atas. Pasal tadi gentil. Di jalan.
Mengucapkan terima kasih kepada Dr. Fauzia atas perhatian dan kontribusi kepada kita.
Majlis seterusnya menjemput Dr. Zainal untuk menyampaikan token apresiasi kepada Dr. Fauzia.
Susah.
You are the best.
Hadirin yang dimuliakan, kita telah sampai di pembukaan acara Perasmian. Saya pihak sudah mengucapkan terima kasih kepada meluangkan masa mereka hadir pada pagi ini.
Dijemput Dr. Zainal Effendi mengenai Dr. Fauzia untuk membuat lawatan booth dan skill station seterusnya menjamu selera.
Everybody just duduk je di tempat masing-masing. Kita ambil gambar saya lah, gambar depan. Siapa yang nak masuk, mengurusi majlis tak masuk. Sekali, satu, dua. Biasa bisa ya. Satu, dua. Okey. Gambar nanti kita akan uploadkan dari komisi untuk penulisan. Sampai ke gambar.
Terima kasih Dr. Faris atas sesi koreografi sebentar tadi. Dan juga Dr. Zainal mengiringi Dr. Fauzia untuk membuat lawatan booth dan skill station. Dan seterusnya menjaga selera.
Semua tetamu kehormat dijemput untuk menikmati sedikit hidangan telah disediakan. Majlis mempersilakan.
Para peserta juga dipersilakan untuk menikmati makan pagi di kawasan luar auditorium dan diminta berkumpul kembali di auditorium pada pukul 10.30 pagi. Sekali lagi diingatkan, peserta diberikan masa 30 minit untuk menjamu selera dan kembali berkumpul pada pukul 10.30 pagi untuk taklimat khusus dan pertandingan.
Syami. Okey
Ya beda kan? Tengah hari program tu.
betul lah beda.
Macam lelu. Kuat sangat lelu.
Tapi kita tiup sikit dah. Dia dah kan tiup sikit
Yalah.
dia tiup. Ya, tarik.
Okey je. Yang
Itulah,
penting
dia
tapi
ada
tak
benda.
betul lah. Tapi dia tak ada meletup lah. Tapi tak apa. Okey lah. Ada purpose daripada belah sana.
Itulah.
Okay. Thank you.
from abroad. Typing. Hi, typing. Kana. Right, hello. And our furthest away guest, Sarike. Yeah, good. Okay, so there will be, from now onward, it will be more casual, alright? Kami akan divide semua orang kepada groups, okay? If you have not seen your groupings outside there, I'll read it again, right? We will start skill station at 11 o'clock, okay? So, skill stations ini, you'll be divided into 3. Room A, Room B, and Room C, alright? Room A, B, C, inside each of the rooms, there are 3 stations. There's airway management station, there's an immobilization station, and there's a trauma-related procedures. Okay, so you move in the room itself, 3 stations. After that, you need to go down for ultrasound station. Ultrasound is just beside here. Okay, when you go to the ultrasound station, you still follow back. If you're from room A, you go to the ultrasound station room A, and B and C. Do you get it? Okay. Just in case you get lost, okay? I will have ushers waiting for you outside each room to bring you to your respective stations, especially when you move upstairs and downstairs, right? Only ultrasound station is downstairs. Other stations are all upstairs. Get me? Yes? Alright, good. Okay, I will just read out the names just in case you guys didn't see the list. Right. Room A, there will be 4 groups. Okay? So Dr. Siti Nazifa, Dr. Muhammad Haris, Dr. Nurul Nasibah, Dr. Muhammad Faris, Dr. Wano Alia Shamimi, Dr. Zainul Ikhwan, Dr. Lim Yiwen, Dr. Azwan Saari. Okay, this is room A, station 1. You start off with airway. Room A, group 2. Dr. Nurul Izzati, Dr. Aimi Shahira, Dr. Lim Shivan, Dr. Julia, Dr. Shalini, Dr. Muhammad Akiuddin, Dr. Kevin Raj, Dr. Noh Faradila. You guys will start with immobilization. Dr. Muhammad Shahid, this is room A, group 3. So you start with Muhammad Shahir, Muhammad Azri, Muhammad Shazmin, Nur Zaina, Nur Azza, Siti Aisyah, Muhammad Nazrul Fadli, Wee Jun Kai. You guys will start at procedures, room A. Group 4, Nur Azwana, Nur Khalifa, Siti Rohana, Rebecca Shen, Nurul Farah Husnina, Fauzi, Nur Azni. You guys will be at ultrasound. So downstairs. Okay? These are all room A. Okay? Okay, now we move to room B. Room B, station 1, Dr. Siti Hajat, Dr. Muhammad Shafiq, Dr. Shi Chunlin, Dr. Ahmad Afiq, Dr. Muhammad Husnul Hadi, Dr. Chen Karyan, Dr. Liu Hani, Dr. Muhammad Ibrahim. Okay? Group 2, still in the room B, Dr. Nur Hanisa, Dr. Nolida, Dr. Sarah Nadia, Dr. Muhammad Nabil, Dr. Muhammad Faiz Shafiq, Dr. Pravin Kumar, Dr. Shamilan, Dr. Muhammad Yusri. Right? Group 3, Izana, Nur Dini Nazifa, Mazlinda, Nur Atika, Nur Emma, Anis Raihan, Mariam, Lim Chuni. Group 3, room B. Now, group 4, room B. Siti Nur Diana, Muhammad Nazran, Navendran, Muhammad Al-Fahmi, Temiga, Nurul Aida Idayu, Narong Ri. All this, you are in room B. Okay? Room C. Group 1. Dr. Xia Jenny, Dr. Kong Xin Yi, Dr. Michelle Tan, Dr. Nurul Afifah, Dr. Toh Chin Heng, Dr. Hafizah, Dr. Nur Ashikin, Dr. Lim Pei Yeng. This is C, station 1. Okay, you are group 1. Then, room C, group 2. Muhammad Ashraf, Normala, Muhammad Samsuri, Zulkifli, Muhammad Khairul, Asmaliza Muhammad Safwan. This is group 2. Group 3, Farah Wahida, Muhammad Nasrul Nizam, Muhammad Amirul Fikri, Rosna, Muhammad Abdul Rashid, Nur Amira, Muhammad Ashbil, Darshana. This is room C, group 3. Last, Eric Low, VN, Intan Shafinas, Nur Rafina, Lim Mingman, Kalai Rasan, Nurul Hana. All this is room C, groups 1 to 4. Are you guys okay? Okay, so if you're moving from downstairs, ultrasound station, to upstairs, you will see these signs. Okay? You will see one of my crew, they will be holding signs like this. Okay? Green color if you're in room C, orange color if you're from room B, blue color if you're from room A. Okay? If you're moving from downstairs to upstairs, look for these people, they will bring you there. Okay? If you're from upstairs coming downstairs, meaning you're only going for ultrasound station downstairs, look for my crew members who are holding these signages. Okay? Same thing. Room C is green, room B is orange, room A is blue. Just follow the colors. Alright? Okay. Now some housekeeping. Toilets are available downstairs, right here. Or if you need to go to the room upstairs, there's the toilet upstairs as well. I think the girls one is this side, the guys one is this side. Okay? If you need the surah later in the afternoon, the surah, you have to walk out of this corridor, go up from the glass door here, this way, yeah, this way. Follow the signages to the surah. Okay? Both the guys and the ladies surah, they're just side by side. Right? If you get lost, call or ask for help. Alright? Okay, regarding the championship, I know all of you want to know. So we're not going to stress you out during the skill station. Just enjoy your skill station. Pick up as much skills as you can. We are going to talk about the championship after lunch. Okay? After lunch, we'll come back here. Okay. After lunch, you will have one more round of skill stations. After the skill station, all of you gather back here. We are going to do the championship grouping throw. Alright? Till then, don't think about the championship first, just enjoy your skill station. Alright? Are you guys okay? Alright, just hang on. We will sort the ushers out and then we'll bring you guys to the skill station. You may leave your bags here if there's not, but take your valuables. Alright?